Can you tell us how you treat brain tumours? What are the treatments? And also, have there been significant advances in recent years?
Yes. Now, I have to now define for you a bit more. You've got about 12,000 cases of intracranial tumours, give or take. Statistics vary between country to country and so forth. Half of these tumours will be malignant, and we're talking about primary brain tumor, intracranial tumors. That means tumors that arose first in the skull, in the brain, the box surrounding the brain and the central nervous system. Then you've got secondary brain tumors, which have started in other parts of the body. Breast, lung is very common, which is very topical now. Skin tumors, only one of them, malignant melanoma, spreading to the brain very often. That's why we're advising everybody to keep out of the sun, particularly in Ibiza, where they're very exposed. And I'm not against Spain, or I would like to say that was just to warn people that excessive sun exposure, when they don't have that type of skin, leads to a tumor, which is very commonly then spreading to the brain. So these are secondary tumors. But let us go back to the treatment of primary malignant tumors of the brain, which will be in 4 grades: grade 1, 2, 3, and 4. The most important treatment after biopsy, and if it's not dangerous for the patient, and the biopsy should be performed if it will not lead to incapacity of speech, movement, swallowing, or any other defect. The tumor is then analyzed and defined on the scan. Most patients will then be referred to a specialist neurosurgeon. Now, some neurosurgeons will not only treat brain tumors, they will be treating strokes and all sorts of other diseases. Now, for these malignant tumors, we now have a philosophy that as much of the tumor as possible should be removed. Now, this obviously needs immense skill by the surgeon. It's done microscopically, so the surgeon looks through a microscope, and otherwise it would be extremely dangerous not to have a field of view, because then vital blood vessels, other parts of the brain could be bruised. So the surgeon gets the best view through a microscope and tries to remove as much as possible right up to the edge of the tumor. Now, I have mentioned, or will mention, and continue to mention, these tentacles. Now, to get these tentacles would be sometimes to remove the whole brain, so that's not possible. This is one of the great challenges in trying to get rid of this wretched disease. But the surgeon tries his best to get to the edge of the tumor without harming the patient and leaving the patient intact. Now, to define the edge of the tumor is not always possible, because to find out what's normal brain and what's tumor, that can be very, very difficult. And the surgeon has to be extremely, extremely skilled. Now, there are radiological and ultrasound techniques. Sometimes a little biopsy is taken from the edge where the surgeon thinks the tumor's edge is, sends it to the lab, and it will come back, oh yes, it's still malignant, and the surgeon will try a bit more. But in the main, we are not there to harm the patient. They've got to wake up at least as well as they were, or try to see that they're as well as they were before the surgery. So the maximum surgery possible is now the philosophy. Now, this has changed dramatically over the last decade. Before, patients with highly malignant tumors were usually left, put on a cortisone type drug, steroids, and their outlook was poor. Now, following the surgery, there's a gap. We want the patient to recover. We want them to be able to move their arms, to eat, to feel better. Then they are usually given radiation therapy. Now, radiation therapy is probably the modality of treatment that's used. It's the most common modality used because it's used in those tumors which can have surgery, those patients that can have surgery, and those who can't have surgery. And the tumors are, to a certain degree, radiosensitive. And I don't want to go over, because in this short conversation, to go through all the scientific factors. One is how much oxygen the tumor has, what makeup, what substances are predominant in the tumor. This leads on to research, but in the main, radiation can be effective to a degree in holding the tumor.
Does it not interfere with the brain?
Yes. Now, this is a very good question, very good. Radiation has a short-term effect on brain, and it has long-term effects. And radiation therapists like myself are conscious the whole time. One, if we irradiate a part of the brain or overdose a part of the brain, because each part of the brain tolerates a different dose of radiation. So if we get it wrong, we really get it big time wrong for our patients. So we have to know the part of the brain we are treating and what dose it can tolerate. Now, this is fortunately now well worked out, so we're very careful. The radiation then in the short term will cause swelling of the brain, but we try to reduce this, or we do reduce it, by cover with steroids. But amazingly, in my experience in Mass General at Harvard University in America, we didn't use steroids, and somehow the patients were just as well. So it's an open question. But certainly in the United Kingdom, they will have radiation, which, as we call, steroid cover. So they'll be given cortisone type drug during the radiation. Now, the radiation will be given over 6 weeks and so forth. Now, the early effects we can deal with, but late effects. Now, this is quite fascinating again to think of this concept. We want to keep the patient alive, but we don't want them as a cabbage. We want them well. We want them to live quality lives. We've got here now quantity, quality to evaluate. Interestingly enough, even if one increases the dose of radiation by 1.5 times the accepted dose, experiments have shown we don't cure the tumor. So we try to be cautious for the short term and the long term. But I'm sorry to say there may be long-term effects of the radiation. Now, what am I really saying? We have a disease that may shorten the life of the patient, and they only live, say, 1.5 years after diagnosis. We give the radiation, and the patient lives 10 to 12 to 15 years. That patient may at that point be less sharp than he would have been or she would have been if she wouldn't have had the radiation. So here we have a trade-off. We have a patient living a short life because we haven't given the radiation, or we give the radiation and the patient, God willing, 10 or 12 years later, instead of being part of Mensa or a great professor at Oxford, would be perhaps, still could be. In my experience, the radiation has less long-term side effects than documented. But I want to be truthful in our conversation. It is documented that the long-term side effects may cause some defect or intellectual defect. And this can, of course, be measured with psychometric testing. And probably on psychometric testing, the long-term side effects of radiation will be shown. But it is less important if you've got a patient who's alive and well and can function, can read, can watch television, can socialize. It will probably be literally an intellectual defect of some sort. So we've got surgery and radiation. Now, the last 7 to 10 to 12 years, we have been adding a drug, chemotherapy, drugs during the radiation. The two act together, and in fact, we've improved results from an average survival of 6 to 8 weeks for literally a few months to 1.5 years. Now, this is not good enough, and I'm sad it's not good enough. The drug we usually called is named temozolomide. It's not a very complicated drug if one looks at the complexity of other chemotherapeutic agents. It's in fact a group of drugs called alkylating agents. It's a drug which I have had the good know very well because it was part of the development of this drug. And if one gives it at the same time as the radiation, it really increases survival. In fact, if it's given alone, it increases survival in those patients who can't have any other form of treatment. So we're giving surgery. Then the patient will be asked if they will have radiotherapy with synchronous chemotherapy, with a drug most commonly used is called temozolomide, but it may not be. And this is the standard of treatment now worldwide, surgery plus chemo radiation. So to go into all aspects of chemoradiation would need another talk on its own, because this is more and more used in other cancers as well as brain tumors. But it's the standard of care. Now, what I mean by the standard of care, this would be the protocol in most good centers in the world now, surgery and chemoradiation. So those are the two treatments. Now, after that, maintenance chemotherapy is considered. So the patient would have for a year or 2 years chemotherapy monthly. It's usually tolerated. And I have had patients for 10 or 11 years on maintenance chemotherapy, and it has kept them well. My longest patient is in fact 12 years, and it's quite amazing. This is why I have always said every fact we give the patient has to be tempered with optimism. However few get through, there's always, always, always a chance. So accurate diagnosis, radical surgery, chemotherapy at the same time as radiation, followed by chemotherapy for 1 or 2 years called maintenance chemotherapy. That is at present the standard of care. Thank you for listening. I hope you found this interesting, and if you did, please subscribe.